And maybe we can kind of now take us through like a procedure and how you approach it, your setup for your anesthesia protocol, and, how you have your patient positioned, if you've got a little music in the background or aromatherapy going. Yeah. Paint the picture.
Yeah. Gopi, I love the aromatherapy.
I know. I'm like added the lavender.
There. Yeah. I think we should just have a masseuse, like someone giving a foot massage during any procedure we do in the nose. People just they would pass out. They'd be so happy, get 5-star Google ratings left and right.
Unless they're ticklish.
Okay.
That wouldn't work.
Well, I don't give foot massages to my patients. So instead of that, what I do is the patient shows up, my medical assistant, she'll spray Afrin and lidocaine in the nose, and then she'll put lidocaine-soaked cottonoids, one in the front of the nostrils, just in front of the nasal cavity on both sides. And we'll let that sit there for about 5 minutes. Then I come in, take those out, and with the endoscope, I will apply 2 cottonoids, these are 1/2x3s, into both sides. And those cottonoids are coated with 10% tetracaine gel. This is a prescription for that patient through a compounding pharmacy. And logistically, it takes a little bit of coordination to make sure we get that prescription in on time, make sure we get it back. But the 10% tetracaine is absolutely fantastic. And so I'll put 1 in the middle meatus and then 1 medial to the middle turbinate, all the way tucked in the back. And this is the same thing I do for balloon dilation of the eustachian tube. After I tuck in those 4 cottonoids, 2 on each side, I'll spray a little bit more Afrin and lidocaine from the sprayer just to kind of coat those a little bit. And then the trick, the key, the absolute bonus thing is to wait. And you wait and wait and wait.
I was like leaning in.
I know. What is the key?
Wait. Ready for this? It's big time. You actually got to give it time for the anesthetic to work. So my MA will set the clock for 15 minutes and it works. I'll warn the patient ahead of time. You're probably going to feel your palate get a little numb, maybe your upper teeth, maybe the back of your throat a little bit, but it's a super nice way to do it.
How do you occupy your time? Are you seeing another patient during those 15 minutes? Are you reading a journal? What do you do? Because it's harder for us to sit through that 15 minutes than it is the patient.
Like every other surgeon, I probably have undiagnosed ADHD too. So I definitely I either see another patient or I'll answer emails. And I tend to do one of these either before lunch or at the end of the day. And I do my procedures that way rather than a procedure day. It just works for me so that if it goes a little bit long for whatever reason, I'm not pushing into my normal clinic. I don't like to get behind. But to go back, I do have music playing. I have the lights down a little bit. And it's just a nice, I'm speaking in a nice, relaxed voice, and no fast movements. Just trying to stay.
In your podcast voice.
I guess.
Sorry, I'll stop. I can't help it. They can clean this up.
With 10% tetracaine, do you have to be do you worry about toxicity? Do you make sure your pledgets are not too soaked, or it's not really an issue?
It has never been an issue in several hundred of nasal procedures, not just PNN ablations. I think I use a total of 5 cc's, and the majority of it stays in the little medicine cup. So my MA will squirt a quarter of that into each medicine cup and then kind of swirl it up with the cottonoid. It's just enough to soak the cottonoid.
And you're not injecting? No needles?
Yeah, no needles. I've done it in the past. Occasionally I have to do it for a balloon dilation of the eustachian tube, but I really like not having blood in the field, and patients really like not having blood dripping down the back of their throat. Just, a little bit of bleeding from the needle poke. And I've just been super happy with it. I've found that I don't have to do it. And if I give the tetracaine 15 minutes, the average pain when I do this is a 1 to 2 out of 10.
What about anxiolytics like triazolam or Valium? Or do people ever want a little something to relax, take the edge off?
A little something. This is the Pacific Northwest, so I tell my patients, do what
CID?
you need to do.
You guys have got all kinds of something up there.
Yeah, in reality, if someone does ask for something, I would give them an Ativan, but it's super rare. And I just tell people, and this is part of the counseling when I sign someone up for a PNN ablation, I say, you're really not going to need anything. If they are super anxious, I say, you know what, let's just take a nap for 10 minutes. We have a surgery center attached to our building, and literally they're asleep for 10 minutes. It's really easy. And, that would be a different scenario if I was in a big tertiary hospital again, and it took like 2 hours to do a 5-minute case. So it's a nice situation to do that.
When you do it in the OR, do you do like just MAC or like some sedation, or do you actually intubate and like do like a full like general endotracheal anesthesia?
It's a general, but it's almost always with a LMA. And that's true for even with my full house sinus surgeries and low throat drill outs. We use LMAs for almost everybody.